everyone. My name is Mingzhu, and today I want to talk about a deep learning method for predicting the outcomes of patients who undergo kidney dialysis. This summer, I worked with Autumn Lab, and my mentors are Dr. Dubrovsky and Dr. Miller. I graduated from the University of Michigan, and this year I will be joining the Robotics Institute as a master's in robotics student. Kidney dialysis is a treatment for people whose kidneys cannot function naturally, and it removes excess water and toxins from their blood. In 2018, 700,000 Americans had kidney failure, and 500,000 of them received dialysis, so this is a very widely used treatment. Our goal is to build a deep learning model to predict the mortality rate of these patients in order to help with clinical decision making. We utilize 3 patient demographic information, including race, sex, and age, and 25 patient blood test results. Demographic information is treated as static variables. Blood test results are collected at different times during a patient's stay at the hospital, thus they are treated as time series. Some patients experience death when they are in hospital, and some patients did not experience death when they are in hospital, and we say the outcomes of these patients are censored, meaning that we do not know their actual outcomes when they leave the hospital. The dataset includes over 200 patients who died and 200 patients whose outcomes are censored. In order to process lab test results, we use a recurrent neural network. Missing values are imputed such that the gap between each observation is 3 hours. We take the last output of the model and combine with the demographic data as input to the multi-layer perceptron, which creates a feature vector for a Cox Proportional Hazards model. It models the probability of death as a function of time. To benchmark the performance of our model, we implement a baseline. In this case, we only use the last lab test results and the demographic information as input to the Cox Proportional Hazards model. Now we utilize less information, so this is expected to perform worse than our proposed model. We use 4 evaluation metrics. Braille score measures accuracy of the model. Concordance index and area under the curve measures how well the predictions are ranked, meaning giving a low risk score for patients who lived longer. Expected calibration error measures how well the predicted probabilities reflect actual outcomes. We evaluate the performance on 50, 100, and 200-day time horizons. A good model is expected to have low Braille score and expected calibration error, and high concordance index and area under the curve. We present the performance of the models. In this figure, you can see that our model has higher AUC and concordance index and lower Braille score on 50 and 100-day time horizons. So our model outperforms the baseline model in terms of Braille score, concordance index, and AUC. Lastly, I want to say thank you to the risk cohort, Ms. Rachel Burson and Dr. John Dolan. I also want to say thank you to my mentors, Dr. Dubrovsky and Dr. Miller, and other members of the Autumn Lab. Thank you.